I'd like to welcome everyone to AHRQ's National Web Conference on Applying Advanced Analytics in Clinical Care. Although a few people are still logging in, we're going to go ahead and get started on time. My name is Jenny Shao, and I will be moderating this webinar. I currently serve as a health scientist administrator in the Division of Digital Healthcare Research in the Center for Evidence and Practice Improvement at AHRQ. This slide shows the agenda for today's webinar. Please note that we are recording this webinar. The webinar recording and slides will be available on the AHRQ Digital Healthcare Research website in a few weeks. You will be notified by email once they are available. We are pleased to have with us today an esteemed group of presenters. They include Dr. Alexander Turchin from Harvard Medical School and Brigham and Women's Hospital, Dr. Judith Dexheimer, Cincinnati Children's Hospital Medical Center, and Dr. Michael Avidan from Washington University School of Medicine. This webinar event is accredited by Affinity CE. For those of you who are interested in receiving continuing education credit for participating in this activity, information on how to claim your credit will be presented at the end of the presentation. It will also be emailed to you after this webinar. For the purposes of accreditation, let me note that AHRQ, TISTA, Affinity CE, Dr. Dexheimer, and Dr. Avidan have no financial interest to disclose. Dr. Turchin has received grants from AstraZeneca, Brio Systems, Edwards, Eli Lilly, Novo Nordisk, Pfizer, and Sanofi. Lastly, please note that no commercial support was received for the development of this learning activity. Just a brief note about questions. We have reserved time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters using the Q&A panel located on the right of the PowerPoint slides. As a reminder, participants are in a listen-only mode, so to ask questions, you will have to use the Q&A panel. This slide shows the learning objectives for today's webinar. By the end of this presentation, you should be able to review how machine learning algorithms in conjunction with natural language processing can be used to identify patients at high risk of death and evaluate the benefits of using EHR integrated machine learning algorithms to identify patients with epilepsy who could benefit from surgery, and describe how data mining and machine learning can help forecast adverse outcomes among surgical patients. And you'll also be able to discuss different advanced data analytics techniques for improving the quality, safety, effectiveness, and efficiency of care. And lastly, you'll be able to identify how to best integrate advanced data analytics into clinical practice. And now it's my pleasure to introduce our first presenter, Dr. Alexander Turchin. Dr. Turchin is Director of Informatics Research at the Division of Endocrinology at Brigham and Women's Hospital and Associate Professor of Medicine at Harvard Medical School. His research focuses on quality and outcomes of care of patients with chronic cardiometabolic conditions, including diabetes, hyperlipidemia, and hypertension, using advanced EHR data analytics, including artificial intelligence and natural language processing. Dr. Turchin's research group makes Canary, the open source natural language processing platform. And now allow me to turn the control over to Dr. Alexander Turchin.
Thank you for your kind introduction. It's my pleasure to be here today. I thank the organizers for inviting me. So I'll start by spending a little bit of time preaching to the choir. We all know it, of course, but just a few numbers that show how abundant exactly electronic healthcare data is. It's estimated that in 2013, we produced 153 exabytes, that's apparently 1 billion gigabytes of electronic healthcare data. And this year, 2020, it's expected that we will have produced over 2,000 exabytes, and I honestly don't even know what to call that number. And that translates into a 48% annual increase. So there is a treasure trove of data we're sitting on, but we're not really making a great use of it for a few reasons. One is that data aren't well organized. They're also siloed. Everyone is sitting on their pile, and we also lack appropriate analytical technologies. So my talk today will focus on this last aspect, the lack of appropriate analytical technologies. There are two main categories of electronic healthcare data. One, here on the left, is the example of a structured data where data are sitting in nice tables from which they're easy to import into your favorite statistical software and analyze and test the hypothesis that you want to test. But a lot of data is in the form of narrative data, just text that somebody wrote describing their interaction with the patient or test results, like the example on the left. And the way to extract this helpful information from the narrative data is to apply technologies that are called natural language processing. As in this example, it extracts from the paragraph above the information that the patient came in with chief complaint of back pain, but did not have trauma or weakness. Just as an aside, natural language processing can also be used not just to extract information, but to generate text. And a few years ago, a couple of students from MIT wrote a software program that generated scientific articles like the one that you can see in front of you on the screen. And they actually submitted this article to one of the conferences to which we all get invitations in our mailboxes on a daily basis. And even though this article, while grammatically correct, is complete gibberish, it was actually accepted at the conference. And my understanding is that the students actually even went down and gave a presentation that was also generated by their software. But back to the natural language processing that serves to extract information, there are, I like to think of it in two categories. One is targeted natural language processing and the other one generalized. Targeted natural language processing aims to identify a narrow set of concepts in the text. It can be used to answer specific operational or research questions. And examples could be to identify left ventricular ejection fraction that's recorded in echocardiogram reports or identify adverse reactions to statins. On the other hand, generalized natural language processing aims to present a broad picture of the patient's condition or emotional state. It can be used for things like predictive modeling, and an example would be to identify patients at high risk for hospital readmission. There are different tools that are targeted towards different types of natural language processing. So an example of a tool that's focused on targeted natural language processing is the program Canary that our group makes, which is a free publicly available software that's geared towards users who don't necessarily have software engineering or programming experience, and offers a graphic user interface to put together natural language processing tools. And then there are, of course, a number of tools that are focused on generalized natural language processing. Some of the better-known ones include Python natural language processing libraries, such as NLTK or Spacie, and there are a number of others. And these offer functionalities such as sentence boundary detection, word stemming, and anagram frequency calculation, among others. One of the more medically focused generalized natural language processing tools is CTAKES, and this also offers a number of functionalities. Among them is UMLS ontology mapping, negation detection, and name section identifier. So next I'll give examples of how both targeted and generalized natural language processing can actually be used in analyzing electronic health data. So the project where we used targeted natural language processing was where we studied lifestyle counseling for patients with diabetes. So not everyone is convinced that lifestyle changes are good or helpful. And in this cartoon, Dilbert's pointy-haired boss doesn't want sweet talk about diet and exercise, but wants pills instead. He's not alone. And one of the reasons is that there are lots of data out there that say that intensive lifestyle counseling is helpful, but this is all based on clinical trials. And clinical trials differ from routine care in a number of aspects. So first, patients who enroll in clinical trials, they enroll because they have agreed to try diet and exercise, but not all the patients that I see in my clinic are as similarly enthusiastic about them. Patients in clinical trials are paid to participate. My patients pay to see me, so that's another important difference. And there are a lot more resources available for participants in clinical trials. I heard, for example, about treadmills being delivered to the doorstep of participants in NIH-funded clinical trials, courtesy of the federal government. That isn't a service that's available to my patients. And as a result, it's not certain whether these findings of clinical trials are actually applicable to routine care and whether lifestyle counseling and routine care is effective. The problem with studying lifestyle counseling in routine care is that there is no structured data that indicates that the patient received lifestyle counseling. There are no checkboxes, there are no ICD codes. It's only in the provider's notes. So that's why the solution was to develop a targeted natural language processing tool to find documentation of lifestyle counseling. This was a little easier than some of the other natural language processing tasks because it turns out people don't say in their notes, I did not talk to the patient about the diet, or I thought maybe I would talk to the patient about the diet, or I talked about the diet to the patient's father. All the usual traps in natural language processing. So this was, we were able to develop a pretty reasonably accurate natural language processing tool. Next, we applied it to a data set of patients who are receiving their care in a regular primary care setting. And we were able to study over 30,000 patients. So this isn't something, it would be pretty expensive to do a clinical trial of this size. It would also be really challenging to do a manual chart review of that number of patients. And we looked at the relationship between the frequency of lifestyle, which is diet, exercise, or weight counseling, and how quickly the patients reached their blood glucose, blood pressure, or cholesterol targets. So these were the results. So you can see here that the more frequently lifestyle counseling was provided, the faster the hemoglobin A1C reached the threshold of less than 7%. And really, you get the biggest bang for the buck when lifestyle counseling is provided about monthly, which is actually consistent with the clinical trial data as well. And we had similar results for blood pressure, where they were maybe even more pronounced, and for LDL cholesterol. And in all three cases, the monthly lifestyle counseling frequency was markedly better than less frequent lifestyle counseling. But these are just numbers, of course, the hemoglobin A1C, blood pressure. What patients really care about is clinical outcomes. And so that was another study that we conducted. We, again, had about 20,000 patients there, and we now looked at the relationship between frequency of lifestyle counseling and the time to cardiovascular events or death from any cause. And again, there is, in fact, a relationship. We here separated the patients into two groups, those who received the counseling monthly based on the data that you just saw, and less than monthly. And so for the composite primary outcome, you can see that this reached a significant difference. And you started seeing a difference about 5 or 6 years into the study, which again is consistent with what we're seeing in large clinical trials of blood glucose lowering treatment. There was a similar pattern for all-cause mortality, which was a component of the primary outcome, though that didn't quite reach statistical significance, and a similar pattern for cardiovascular events, which did reach statistical significance. Next, I was going to discuss a project where we used generalized natural language processing to create a predictive model that would identify patients with low life expectancy. So at the population level, something like that could be really helpful because it would allow us to improve our analysis of quality measurement, decision support, and outcomes research. And we tested machine learning technologies as well as generalized natural language processing for this purpose. One of the machine learning technologies we tested is called dynamic logic. It showed really nice results in image recognition, so we thought we would test it in medical predictive modeling. How its performance in image recognition is illustrated on this slide. It's supposed to recognize 3 lines that are hidden in this mass of dots. These are the actual lines that it's trying to recognize. And you can see how over a period of several iterations, it zeroes in on pretty much those 3 lines that we cannot really see with the naked eye. So we studied a data set of patients over 40 years old, where we looked at them every 12 months, and we tried to see if we could predict whether they would die or not over the subsequent 12 months. So we resampled the same patient a few times and adjusted for that. We overall had about 630,000 patients. We had an 80% training and 20% validation data set, and there were no overlaps patient-wise between the training and validation data set. And initially, we include demographics, diagnosis, procedures, medications, lab tests, and vital signs. In one of our first iterations, we compared for the entire data set, 40-plus-year-olds, logistic regression, support vector machines, and dynamic logic. So they all performed pretty well. They all performed pretty close to each other. The reason they performed pretty well is that it's not actually that hard to predict mortality in a 40 or 50-year-old over the next 12 months. Most of them, fortunately, don't die. So if you just say that these people aren't going to die, you're going to be pretty accurate. So next, we tried the same algorithms on 65-plus-year-olds. So now we have higher mortality rates, and so it's a little bit of a greater challenge for the algorithm. We tested a few more algorithms. We now also tested feed-forward neural networks with 1, 2, or 3 hidden layers. And again, the performance was lower as expected. And again, the performance of different analytical techniques was pretty close. So next, we thought that there is a lot of information that's not being captured in the structured data. So we would try natural language processing, but now we didn't know specifically what the predictors might be. So that's why we use generalized rather than targeted natural language processing. A lot of it involves just cleaning up the mass of text, terabytes and terabytes of text that we had to analyze. You have to remove things that are not words, like HTML tags pop up out of nowhere, identify individual words. Even that is sometimes more challenging than you would think. Exclude words that are either very rare, so probably a misspelling of some sort, or very common, such as articles or prepositions or pronouns, and so are not going to be very informative. And finally, we did what's called TF-IDF normalization. Essentially, this approach gives the highest weight to the words that have high frequency in one particular document, but low frequency in the overall data set. So there is a contrast, and that contrast indicates that the word might be meaningful. So here we tested the logistic regression model, and which achieved area under the curve of 0.94, so significantly better than any of the models that did not use natural language processing. This was on the population aged 65 or greater. And we also looked at the words that were flagged by the model as particularly predictive of low life expectancy. And a lot of these made sense to us clinically. And you may think, well, this is obvious that, hospice or metastatic cancer, that would indicate that the patient is at high risk of death. But it's not actually that easy to get this information from structured data. There is no easy way, for example, to identify metastatic cancer from ICD codes. You can know that somebody has cancer, but whether it's easily resectable and easily treatable tumor, or it's tumor that's already metastasized all over the place, that's not really going to be reflected in ICD data. So that's the big contribution that natural language processing could make. So what do we conclude from these results? One conclusion is that targeted natural language processing makes possible clinical research that is really not feasible using traditional analytics, because no matter how many clinical trials you conduct of lifestyle counseling, routine care is different, and the only way to study routine care is to look at data that's generated during routine care. On the other hand, what generalized natural language processing, where that comes helpful, is that, as you could see, a lot of the machine learning techniques performance was very close to each other. So where you really get an improvement in these analytics is if you bring in a new data source that has data that you didn't have before. That gives you much better improvement in your performance than using a more sophisticated analytical method. And finally, I wanted to thank all my colleagues without whom this work would have been impossible, and I wanted to thank AHRQ for funding our research. And I will pass control to the next speaker.
Thank you, Dr. Turchin. As a reminder, we will be taking questions after all the presentations. So please submit any question you have using the Q&A panel. Let's move on to our second webinar presentation by Dr. Judith Dexheimer. Dr. Dexheimer is an associate professor of pediatrics at Cincinnati Children's Hospital Medical Center in the divisions of emergency medicine and biomedical informatics. Dr. Dexheimer's research focuses on the development and implementation of machine learning directly into clinical care. She's interested in research on developing automated tools to help support diagnosis, decision support, and creating informatics applications that can be implemented across health systems to improve generalizability. And now I would like to turn the control over to Dr. Dexheimer.
Okay, thank you very much for that introduction. I'm going to talk about a project we did about identifying and then implementing optimal methods for notifying clinicians about epilepsy surgical patients here in pediatrics. And so I don't want to repeat too much of what Dr. Turchin has already talked about the electronic health record, but I wanted to provide kind of a brief introduction about the EHR. So what is your EHR? It's where all of your hospital and ambulatory visit data are stored. And it was designed for billing, but it can be used for research as well, which is what we're going to talk about today. What does it contain? We've already gone through a little bit of this. It has both that structured data, like your vital signs, and the unstructured data, like all of your notes. It's important to note that there are more than 300 electronic health record vendors in the United States, and more than 75% of hospitals report having an EHR, and more than 80% of pediatricians report using an EHR. And so what there is in the EHR is a lot of data. And it's a lot of data, it's a lot of communication, and it's a lot of good things that we could look at for research. And so one of the questions I wanted to answer for the world is what is big data? Because this is commonly discussed, but we don't ever go back to look at its source for it. So I went back to find the source of big data, which is from 1997, from a paper published by NASA. And the answer is big data are data sets that do not fit in main memory or in core memory. And when they don't fit on a local disk, the most common solution is to acquire more resources. So this tells you the actual firm definition of big data, but with the way that memory capacity is continuing to increase, so is all of this storage, and so big data kind of begins to fade away as we go, even though we're looking at really large data sets all the time. So the next logical question is, what's in the EHR? Are those big data, and how are big data being used in healthcare? So the EHR stores, as we just talked about, a large amount of patient data. And so with that widespread digitalization in healthcare, there's an exponentially increasing amount of data from a lot of different sources. So if you wear some kind of fitness device that tracks your steps, your sleep, etc., there's the potential that all of these things could be updated, integrated with your EHR data, eventually increasing this exponential increase as you go along. So there's a potential rich source for research and data mining with this. And about 80% of health data is reported to be unstructured, which lets us look at things like natural language processing. So as an easy kind of small example, here at Cincinnati Children's Hospital Medical Center, we're one large hospital. We form a catchment area of most of the pediatrics in our area. We have about 1.2 million patient encounters annually, and of those, in our 10 years of EHR data, we have about 40 million visits worth of data. So that tells you what we have and what we are sitting on to give you an example of what might be happening off in the rest of the world and all those other EHRs. So what I think is most important on the data, and then we'll get to the project as well, is that thinking about the fundamental theorem of informatics, which is that the computer plus the human should do a better job of helping people than just the human alone. So the point I want to make is that the professional judgment is always going to be vital to shaping care. So we are always going to need the providers involved in all levels of our care. But given the amount of information required for any given decision, it's too much. So it's moving beyond unassisted human capacity. Our patients on our pediatric neurology side have over 10 years of care, and there's no way for a provider to go through and read all of those notes and make sure they know every single key piece of information before every single patient visit. So what we aim to do is to create a tool for providers to improve care and then ultimately to improve patient outcomes. So what I want to talk about, to give you a very brief clinical overview, is our project with epilepsy. So epilepsy is one of the leading neurological disorders in the United States, and it affects more than 480,000 children and over 2 million adults. About 30% of epileptic patients are intractable, which means that even with appropriate treatment with medications, they continue to have seizures. In pediatrics, 55 to 59% of children are seizure-free after appropriate neurosurgery, and of those, about 77% have an improved quality of life. So what we want to know is, can we identify them earlier for those who might be eligible for surgical intervention, and can we differentiate between intractable and non-intractable patients using natural language processing and machine learning, and looking into those large amounts of data currently available in the EHR. So a brief overview of surgery identification. So early identification and referral of children to surgery who are potential candidates is laborious and complex. At Cincinnati Children's, our average from time of diagnosis to time a patient might be sent for consult is approximately 6 years, with a national average of approximately 10 years. The patient outcomes after surgery are good. The complication rate is very low at about 3%. And while there are general rules that exist, including the International League Against Epilepsy to help identify patients who are going to be potentially eligible for consult, and there are decision support rules as well, they aren't streamlined, and they aren't automated, and they aren't implemented directly into clinical care. And these were the problems that we wanted to fix and try to help with. So first, kind of as a giant overview, let me talk to you about what our natural language processing algorithm does. So here on the x-axis, you can see from year 1 to year 10, this is a patient's visit history with us here at Cincinnati Children's. Got it. There are 2 different lines that's happening here. This first purple line on top is actually the neurologist language of intractable patients in their clinical notes about these patients coming into neurology. And then this light blue line here on the bottom is the neurologist language of non-intractable patients. Using natural language processing, we can identify a difference and a shift in how these neurologists are talking about their patients. So what these little E's are designating here for you are a patient's visits with the neurology clinic from year 1 to year 10. And what it's showing you is that if a patient is actively having seizures, they'll come back every 3 to 6 months to visit their neurologist and have their medications addressed and look at things to have things move forward. So here at year 6 at our average, this is where we send a patient and we say, hey, you may be eligible for surgical consult. Let's go ahead and send you out and have you seen by a provider. What happens here is with our natural language processing algorithm, we can identify the patients here at year 4. We're supposed to stop at year 4. So I'm not going to over-promise us yet. And so our goal was to take this, evaluate it prospectively, and then implement it directly into care so that we could be identifying those patients at the 2 years earlier mark. The other thing I wanted to give you is a very, very brief look at, well, why does it work? Why do you trust it? So what the algorithm did is it looks to automatically differentiate between the seizure-free and those eligible to be referred for surgical evaluation. I have picked the most basic of examples here for you in the phrasing of the notes as to what might be an intractable patient are those who could be referred, and what might be a seizure-free patient are those who are not referred. And among these trends in the intractable is the word surgery, idiopathic localization, increase, which likely relates to seizures, and of course epilepsy. And then of those that may be seizure-free and may never need a referral include excellent control, bilaterally, and first. And so what we want to do is talk about, now that we've done this and now that we know it's going to happen, how are we going to take this algorithm that we developed with neurology, and neurosurgery, and then we're going to put it into practice. And so there are a couple of steps here to highlight, and the first one is to involve the end users in the intervention design. As I just mentioned, we had neurology, we had neurosurgery, and we had informatics all involved in the creation, development, and testing of the algorithm when we did it retrospectively. This allowed the neurologist to be able to trust the results, know what went into it, and make some determinations about what might come out in the end. And then the second and an important thing when putting it into practice was to automate all the processes to run without additional interventions. We wanted to make it as easy as possible for the providers without requiring them to do any additional work. So here's what we did. Patients come in and have a pre-scheduled visit. So we run our natural language processing on everyone who has a visit coming up in the next week in the neurology clinic on a Sunday night. And on Sunday night, we make a determination using the NLP, and we say, you may be an eligible patient or you may not be. And then based on that, we send out a set of alerts. There are 3 different arms in the study that I'll talk about. One of them is the control arm, which is standard of care, where we do nothing. We do not provide any additional information from the machine learning piece. The second is to send an email to the provider. And this email states, and I will show you an example, that the patient may be eligible. Here is why they might be eligible, and you may want to go review their record prior to their visit today to make up your mind as well. And then the third is an in-basket message through our EHR that says the same thing as the email, but is there entirely to help the providers see it in a more in-line way with the way they view the electronic health record. And so what happens is we automatically identify patients on Sunday, and we send everything out to the providers and let them get started. So here are the sample reminders for you. And the top here with the number 1 is the email. It gives the patient name, their medical record number, and lets the provider know who they can contact. The key contact is me right now as the study. And then it has all of the providers who helped as well with the design and implementation so that they have a peer they can contact and talk to about it as well. This number 2 shows that we created an entirely new basket in the in-basket so that you would know it's either blank or it has a 1 or a 2, as you can see in some of these others, so that you know you have something that is a surgical consult recommendation and you can check on it. And then the number 3 is the message, which looks exactly like the number 1, but it allows you to complete your message, to follow up, and to say, you know what, I want to go ahead and schedule them. And all that can be done within their care. So let's talk about whether or not any part of it worked and how well it did. So the first and most important thing we did was we evaluated the actual natural language processing algorithm, where we ran it every single week and we evaluated every patient who came in. And we had 2 board-certified neurologists go through all of the notes and say, yes, this patient said they were eligible and they truly were, or they weren't. So the first thing we want to do is we looked at all of the patients coming in for a 1-year period, and that's 4,211. And we assigned them a surgical candidacy score. And of those who were assigned a score, we had about 300 who were potentially eligible for surgery and were reviewed by the neurologist. What you see here on the right is how well our algorithm did. Our area under the curve was 82%. We had an 80% sensitivity, an 83% specificity, and our positive predictive value was 40%, and our negative predictive value was 97%. Our number needed to screen, so in other words, the number of alerts we would need to provide to send 1 patient was 3.6. So for every 4 alerts that we send to a provider, 1 patient should be sent for surgical consult. A quick note about the positive predictive value being so low is that because the prevalence of patients eligible for epilepsy surgical recommendations is actually very low in the large population when you look at all possible neurology patients coming in for a visit. So the next thing to show you is let's look at what a patient trajectory might look like looking at this screen. So what you see here is the blue to the red scores. These are weekly scores for 1 particular patient who ultimately ended up receiving surgery, showing their pathway from not eligible for surgery with good control and appropriate control here on the blue up to the red and over the candidacy score limit where this patient may need to be sent for surgical evaluation and then ultimately was. What you see in the gray bars on slide B are the 95% confidence intervals showing you how confident we are in each of the scores we received. The idea behind this is just to illustrate and show you what a typical patient pathway could potentially look like and what a provider might like to see in the future based on the scores. So we've evaluated the NLP system. The next thing we want to do is evaluate the actual providers. So what we did is in a different one-year period, we took all patients who had an epilepsy visit with an ICD-9 or ICD-10 code, which is 4,800 patients, and then we ran all of those through the classifier. This was the Sunday night thing. And then on Sunday night, we got a total of 284 patients over a one-year period, and we randomized them to those three groups, the control, the email, or the EHR alert. So this image is illustrating for you that what we did not do was over-alert our providers and contribute to alert fatigue. The red line here in each of these dots is a number of alerts sent every single week, and this is shown over a 2-year period. And this blue line here is the number of surgical candidates identified. We actually have a very low range. It goes from 1 to, we have 15 there, was at the maximum in 2017. But we have over 20 neurology providers, and so at no point in time was anybody getting inundated with alerts on Sunday nights prior to seeing all of their patients. So the next thing we want to show you is what actually happened when we sent these alerts to the providers. So what you're looking at here is the cumulative number of patients in the control and alert groups who were referred for pre-surgical evaluations. This red line here on the left side is the control group, and the blue line is the alert group, and that's combining both types of alert, the email and the EHR alert. Patients who were randomized to the control group on both images are shown in red. In the version on the left, the patients who received any alert were grouped together. They were C and the bottom numbers that while there were a number of alerts, those in the parentheses show the total number of patients referred. You can see that even when we break them out between control and EHR alerts, both suggest a trend towards referring more patients to surgery with an alert compared to no alert. So the actual statistics to give you a better image to look at here for this one is to look at this forest plot from our multivariate Cox proportional hazards. After adjusting for age, visits, the total number of anti-epileptic drugs prescribed over treatment, and the total number of alerts increased the likelihood for surgery here. Although it is non-statistically significant, we have 0.06. However, we had more patients seen and sent for surgery after an alert than we would have otherwise. So what were some of the benefits of the EHR integration here? And the first and most important is the provider involvement in the design. So the providers were there for us and worked with us for the identification system originally, and then they were there for us, and the providers actually picked the type and when they wanted to receive those non-interruptive alerts we provided. We identified more patients compared to no alerts whatsoever, and we have been following these patients for 3 years, which is part of what was in our cumulative plots to show that we are following up to see if we do indeed improve that 2 years earlier mark than what we had before. Another benefit was that the providers were able to decide prior to the visit. They were not asked to make such a large decision, including neurosurgical evaluation during the visit. And then the decisions could be deferred until a future visit to give time for discussion. So we evaluated with the patient as the unit of analysis, and so patients could have multiple visits, and 16 patients went from the control to the alert group over the 1-year study period by having a second follow-up visit indicating that they were still having seizures. So a next good question is, see, what can we do next? And of course, looking at our positive predictive value, one of the important things we can do is improve the classifier. So we can add in additional data sources. We can look at some of those structured data sources that we discussed before. A benefit of our natural language processing is it used entirely notes and only notes. And so what happens if we add in structured data? Can we make it better? And can we help improve the patient care? Another is to more fully integrate it with clinical care. Maybe there are other decision points and other times that providers might be thinking about making a recommendation, and we can help it with that. And then the last one's to expand to other hospitals. We have some data suggesting that across all pediatric hospitals, there are linguistic features that are the same, and we could go ahead and expand out from Cincinnati Children's to another eligible hospital and try to identify more patients. And so the question for us is, what does the future hold? So we can certainly improve pediatric care with unbiased machine learning algorithms, and we can provide more opportunities for machine learning development and implementation. There's a significant amount of data still untouched in the electronic health record, and we could apply more algorithms to help identify patients with more complex diseases. And then we can do more testing across larger data sets in hospitals. And so with that, I want to say thank you, and I want to say one more important point in research, which is that nothing is possible in research without highly collaborative teams. Once I put members of all of my teams as pictures at the ends of my slides, and I want you to know they all ended up looking kind of like mugshots. And so I don't do that anymore because it's not a good skill in my life. But I want to thank several people. The first is John Pestian in the Pestian lab that did the work developing the original algorithm, including the neurologists and the neurosurgeons, Hans Greiner and Katie Holland and Francesco Mangano. And the last one is my PhD student, Ben Whistle, who is taking some of this work and working on some of these future plans for us to try to improve some of these pieces and implement them into other areas as well. And a lot of people who are not mentioned but are vital to having important and improved research. So thank you.
Thank you, Dr. Dexheimer. So please feel free to submit any questions you have using the Q&A panel at this time. So moving on to our final presentation of this webinar by Dr. Michael Avidan. Dr. Avidan is the Dr. Seymour and Rose C. Brown Professor of Anesthesiology at Washington University School of Medicine in St. Louis. He is an investigator in perioperative outcomes research, including large clinical trials. One of his major interests is in the potential for healthcare advancement through combining human expertise with innovative technologies, including telemedicine and machine learning. And now I would like to turn the control over to Dr. Avidan.
Thank you very much, Dr. Zhao, and thank you very much to my co-panelists, Alex and Judith. It's a great pleasure for me to be presenting to you this afternoon, or whatever time of day it is where you are. I'm going to try in a few minutes to weave a narrative and to tell you a story, and I hope you'll be able to follow my thread. I don't want to leave thanking people till the very end, so I do have a few slides just thanking the so many people who have helped to make this work interesting, successful, and most of all, enjoyable. So these are some of the team members who've worked on the projects that I'll be talking about. In particular, will be the ACTFAST 2 project. I also want to give a big shout out to the many clinicians, the anesthesiologists and the certified registered nurse anesthetists who have worked in our anesthesiology control tower and have enabled the work we do. I have no conflicts of interest to declare, as has already been stated, but I certainly want to thank the Agency for Healthcare Research and Quality for enabling this work. And I want to point out this is actually taken from the AHRQ website, where there are really helpful summaries of research that has been done. And I think for those of you who are aspiring to do research, to write grants, look at the AHRQ website, because that's where you're going to get really good tips from those of us who've summarized our research there, and you can see how to format reports, and there's a ton of useful information about how to write grants. What I wanted to point out in this particular slide is from the summary, one of the key words on this slide is Dr. Avidan and his research team at Washington University. None of the work that we've done and that I'll be presenting today would be possible without team science and without drawing on the phenomenal and foundational skill of so many members of our team. I have some skills for sure, and I do contribute, but there are many deficits, and I love working with other people who complement the work that I do. So many of you have thought about air traffic control towers, and these have really improved safety in the aviation industry. And in ICU care, I'm an ICU physician and also an anesthesiologist. I think about the complexity where there's so much going on, and how do you keep an eye on all these moving parts? So we thought about what if we could set up an anesthesiology control tower in the perioperative space, where, as an analogy, we would need a dashboard and we would need a good graphic user interface. In this case, the software has been provided by a company called AlertWatch, in which I have no specific interest, but they've been very helpful in working with us to provide an interface that works for a control tower, monitoring multiple operating rooms, in fact, across multiple locations. And we use this as a template to build the study today, to which I will be referring. So you can also get more details on this work from the report that is posted on the AHRQ website, and the URL for that is shown at the bottom of this slide. And there were 3 aims of the particular grant that was funded by the AHRQ. And I'm going to be focusing only on aim 1 today, which is the development, refinement, and validation of forecasting algorithms for adverse post-operative outcomes. And in fact, we were developing, or we have developed, algorithms for various adverse outcomes. But because I'm weaving for you just a single narrative today, I'm going to be focusing only on our algorithms looking at post-operative mortality. And actually, you'll see in my talk that I certainly pick up on themes from both Alex and Judith. So I hope that they will also appreciate the way that our talks really meld together very nicely. There was an important usability assessment, which is published separately. And we also had a clinical trial looking at the improvement of surrogate outcomes of quality. But as I said today, I'm focusing only on one thread of the narrative, which is forecasting post-operative mortality. One of the other important lessons that I'd like to convey that I learned as a researcher and that has served me so well is whenever I do a study, regardless of the type of study, I always publish the protocol. So you'll see that early on, and in discussing with our program officers, our very wonderful partners at the AHRQ, we published the protocol for our study with the detailed statistical analytical plan. And that way you're saying to the scientific world, this is what we're doing, this is how we're going to analyze our data, and then there is good scrutiny and a good way to check that scientists are actually doing what they say they're going to be doing. And I think that helps with reliability, reproducibility, and the highest rigorous and ethical conduct of science. The study that I'm focusing on today actually was published last year in the British Journal of Anesthesia, and the first author on that is Bradley Fritz, a very talented scholar and anesthesiologist and intensive care physician, and he and several others like Ryan King, Yijin Chen, and I'll call out somebody else subsequently who did a very important correction to this work. So I'm going to tantalize you with the point over there. This work required an important correction, so listen out for that. So what we did is we thought, how do we take all this complex information? Judith was referring to this earlier. You've got a ton of information. You've got a patient before you. You've got their whole historical data, and you've got all this evolving data in the operating room in the perioperative period, and their risk is changing dynamically over time. Can you utilize artificial intelligence and machine learning to help you get a sense of which patients are going in the wrong direction, where is the risk increasing? And that was the conception for the forecasting projects that we were building. So we have these modifiable risk factors that are things that we can hopefully change. There are some patient characteristics that we can't change, but can be very important in terms of prediction. And then there are time series data which can reflect changing risk, especially in a period of rapid change like surgery, where you can have blood loss or periods of low blood pressure, which would modify risk on an ongoing basis. We actually had about 110,000 patients in our data set, which were whittled down to 95,000. We had a lot of features or variables containing both continuous and discrete variables. And then in the intraoperative time series data, we initially started with 20 series of features, which we whittled down to the 10 most important ones. And then we looked at different bins of time periods to see which were most helpful in the model. It actually varied with our first approach and our second approach. Initially, the 60-minute bin was the most useful, and that's the one I'll be talking on first, but you'll see subsequently with the correction, it's changed to a different time bin. And the data set was split into three: a training, a validation, and a testing set. And we used different models to try to predict postoperative mortality, from fairly complex machine learning models like a multipath convolutional neural network and others which were much more conventional, like logistic regression and random forest models. And the idea behind using these more complex models is we thought that they would be better at handling the dynamic time series data and would give us more accurate prediction of postoperative mortality. As it turned out, all the models functioned reasonably well, but also in a reasonably similar fashion. So you can see that logistic regression was pretty similar to a support vector machine and random forest, as well as the two neural network models that we employed. All of them had area under the ROC of approaching 90% and reasonable precision recall curves. And we published that, and you might think that that was the end of the story. And the positive predictive value for mortality was 10%, with the background incidence of mortality of 1%. So a fair improvement. So in other words, any patient coming for surgery had a 1% chance of being dead at 30 days, whereas our models improved that to, say, 10% positive predictive value. Interestingly, somebody joined our group named Mohammed Abdelhak, who is a postdoc in our group and has worked closely with Brad Fritz, Ryan King, Yijin Chen, and they went back and looked at the data and they noticed something strange. And this is where I think that you'll find the narrative really takes an interesting turn. And what they discovered is that it was true that all of the deaths that we had identified were true deaths. But interestingly, other deaths were appearing in the record which had not previously been identified. And this occurred because sometimes patients die after they're discharged from hospital, and then those subsequently find their way into the electronic health record. So what we did is our due diligence, and we redid the analysis with all of these additional deaths. And in fact, we found that the mortality at 1 month was 2.4% rather than 1%. It's important for me to emphasize that all the deaths that were identified were in fact correctly identified, and that's why these models did perform reasonably well. But in fact, we were missing a whole lot of deaths when we did the original work. And when we redid these models, and I think what you will see from these tables is our originally published results compared with the updated results. So in the originally published results, the area under the receiver operator characteristic curve were in the high 80s, approaching 90%, with the area under the precision recall curves being about almost 10%. With the updated curves, and interestingly, the one that performed the best was random forest, with an area under the receiver operator characteristic curve of over 92% and an area under the precision recall curve of almost 41%, you can see a big improvement. There are a couple of reasons for the improvement. The one reason for the real improvement in performance is simply that we had more accurate data. Our labels or the deaths were more accurately identified, and therefore, unsurprisingly, our models performed better. Another reason ties in with something that Judith was saying to you, was that because the incidence of mortality was higher, the models actually performed better. It's difficult to build models for rare outcomes. So the fact that the outcome was 2.4% rather than 1% also contributed to the improved performance of our models. I also want to mention something that isn't in these slides, which is calibration of the models. And that what we also looked at is observed versus expected mortality, going all the way from the low to high mortality. So from those, we binned patients in various mortality bins, so from 0.4% to the 60% mortality bin, and the observed versus expected mortality really had a very tight, almost a straight line correlation, showing that the calibration of our model worked very well. So, I think there are some really interesting lessons over here. We certainly had a lot of enjoyment figuring out what we did wrong, how we could improve things, and getting the models better. And models that are intended for use in clinical space and that can impact patient care need to be continuously reevaluated and updated, which is something that we did over here. Fortunately, there was no harm that came to patients with application of these models. In fact, we hadn't been using them in real time, whereas we are using them in real time now. But incomplete labeling of a target variable, and I think that is a more common problem than features. Features are more usually accurately identified, whereas outcomes or labels can sometimes be missed, which is what happened to us in this particular event. Here is an image of people working in the anesthesiology control tower. This is a stylized image of the application of the machine learning algorithms in the environment. We now have them live in real time in the anesthesiology control tower, as well as data from the electronic health record, the AlertWatch software to which I referred, video feeds from the OR, and physiological waveforms as well from the operating room. And these are clinicians working in the anesthesiology control tower. This is an example of what the graphic user interface with the dashboard. It's like a pilot would want to get a quick view of how a patient is doing, where green is good, yellow is borderline, and red is bad. And with the machine learning algorithms and dynamic risk, you could imagine that we would get alerts of risks going up and of risks decreasing. So a patient's risk of bleeding, heart attack, respiratory failure, death are all increasing, and for some reason the risk of renal failure is decreasing. And that would be examples of dynamic prediction based on implementation. So I wanted to give you a coherent story about one of our projects, tied all together, and also have a nice link to the work that Judith and Alex are doing. And I think at this point I will end my brief presentation, hand back to Janie, and I'm sure that all of the panelists will be happy to take and address questions.
Thank you, Dr. Avidan. And thank you again to all of our presenters for their very informative presentations. As a reminder, please submit any questions you have using the Q&A panel. So this concludes the content portion of the webinar. Now we have a few minutes left for questions. You can type them into the Q&A section of the WebEx portal. We may not be able to get to them all, but we will answer them all in writing and send the answers out to all attendees. So now I'll start with Dr. Turchin. and I've got a few questions for you. So, what is the proportion of positive and the negative outcomes in the data?
So I think this is probably referring to the mortality prediction project. We had 1% mortality. I'm sure there were some that we missed, but we got our mortality data from Social Security Death Master File, which is our data warehouse matches to our patients. So we're hoping that we didn't miss a lot.
Okay, thank you. And for the next question would be for Dr. Dexheimer. So can you please elaborate a bit more on the process to identify the keywords?
I can. So originally when we developed the algorithm, we actually did quite a bit of annotation using clinical fellows to help us out. And we identified keywords and things that may trend towards intractable or intractable epilepsy, and then allowed those to go into the natural language processing to help improve its classifiers.
Okay, thank you. And the next question is actually for all of the panelists. So what is one of the biggest challenges or limitations of using natural language processing on unstructured EHR clinical data? So I'll, since Michael, you haven't spoke, so would you like to start first?
Well, I mean, we didn't use natural language processing in this particular approach. I think one of the biggest challenges maybe of the approach is the trade-off when you're doing an approach with machine learning, and even if you've got very accurate models, sometimes you have a trade-off between the accuracy and precision of the models and interpretability of the models, because you get a result and you say, oh, this patient is at high risk for death. And you don't know what to do with that information if you're not able to know which features give you that heightened risk of that bad outcome. And that's one of the biggest challenges in this field. One of the ways that we try to deal with that is a technique called back propagation, where you try to look back and eliminate certain features and see how the model performs. When you've got simpler, I don't want to say simpler, different statistical approaches like logistic regression, which was one of the approaches that we used, interpretability is much more straightforward. But I think that one of the things that our group is working on a lot is this problem of interpretability and making sure that the models that we choose we are able to figure out which features are most likely to be contributing to the, in this case, mortality, but the other outcomes like renal failure, respiratory failure, so that the clinician might have something useful to inform what she or he is doing, and that it isn't just a red flag which has no useful information for the clinician. So it has to be clinically useful.
Thank you. Judith or Alex, would you like to comment?
So I couldn't agree more, of course, with Michael that clinical relevance is should be at the top of our priority list, and I think both Michael's and Judith's projects are great examples of how we should pick how projects that we pick are very clinically relevant. Fundamentally, with respect to natural language processing and developing tools for natural language processing, one of the fundamental challenges is the very rich imagination of the creators of the data that we analyze, of clinicians who generate these texts. Their language is very rich. So there are lots of different ways in which they say the same thing. And the more accurate you want to be, the more of this you have to capture. And that ultimately is still the rate-limiting step in developing of natural language processing tools.
Thank you. And so your comment actually leads to the next question. So do you provide any training to providers as to how to organize structure or improve their note-taking to inform and improve the performance of the machine learning algorithms or natural language processing? And if you didn't do that for your project, do you think that would benefit the research going forward? So this is also for all the panelists.
So I'll start as the pure informaticist and not provider. We don't provide any additional training that you did not already receive in medical school to create a structured note to put things together. One of the beauties for us is we take what you're already writing and what you're already comfortable doing and try to interpret it and put it all together for you.
We have the same approach.
Okay, thank you. So I guess, Michael, do you want to comment on this one?
So the training that that we provide to people is really I also wanted to just comment on the innovative aspect, that I think that you know, the whole setting, it's not just the machine learning that is a bit foreign. It's this whole concept of this control tower for this operating suite and bringing machine learning into it. It's a lot for clinicians to assimilate and to deal with. And I think that we're still in the early stages of incorporating the machine learning, and we're only bringing in the one prediction initially, which is the prediction of mortality. I think it will become more complex when there are more predictions. And also, I think the challenge for clinicians is how to respond to data that are really new to them and that they haven't had to encounter in the past. You know, so it's not a risk predictor that is contextually part of anesthesiology training. And I think it will be important for them to understand the limitations. And it's also a point that Judith made earlier, is the importance of having a human in the loop, that there is judgment, that you know, if you see a prediction that doesn't make sense from a clinical perspective, it shouldn't really override your judgment. And that's also something important from an ethical standpoint that our IRB was quite concerned about, that there should be certainly at this point, but we're not ready for prime time to deliver alerts straight to clinicians in the operating rooms, and that there should be this intermediate level of the clinicians working in this anesthesiology control tower. But certainly we have training and education of our clinicians, which is ongoing and occurs in parallel with the development of the algorithms.
Thank you. And the next question is also for all the panelists. So what kind of IT products or vendors did you use in your project? So did you have to do a lot of data cleaning? Otherwise, like did you hire someone else or other team to do it? And did you have data librarians involved? And if so, how useful were your data librarians? So who would like to respond first?
I can start. So we generally develop our own tools for our analytical work. So Canary is one example, and we also developed our tools for the Generalized Natural Language Processing project. Data cleaning is a huge part of any of these analytical projects, and we tend to do our own because every data source is dirty, but every data source is dirty in its own way. sort of like every unhappy family is unhappy in its own way. And so our goal is to have professionals who work in our group who are familiar with our data sources and are familiar with the problems that can be encountered and are on the lookout for those specific issues when we're cleaning the data.
So we are very similar. We have a very common and popular commercial electronic health record here at Cincinnati Children's, but all of our NLP and everything else we wrote ourselves and we're homegrown. And so to answer kind of the data cleaning question, I completely agree. There is quite a bit of data cleaning that is involved, and we did not use data librarians, although that is certainly an interesting idea for future projects.
I mean, on our end, we have several groups of people who are doing this. We have somebody whose sole task is to work on data integration, looking for mistakes in data, merging data from various data sources, and he's amazing and contributes a lot. But all other members of the team were doing various other aspects of that, from the computer science side under Yijin Chen, who is the co-PI on this project. And, you know, just before I forget, I'll come back to this after. There's another point that I really want to make as an encouragement to people who are listening to this talk. But data quality, I mean, I think one of the key lessons from the talk that I gave is that you can, when you have problems in your data, you get the wrong results. And we had, missed the key outcome of mortality in over half of the people who died. And although our model still performed reasonably well, you can see what an increment we got by having accuracy. When you're merging data sets, which often occurs, I mean, I think that Judith is right that we're moving towards more integrated electronic health records, but the data that we were working with were coming from separate electronic health records, and we were still merging them. So a lot of room for error to occur. And when you have mistakes in your data, it's a very, very big problem. The point that I wanted to make, which I'd intended to make in my talk, and that I'm glad that I remembered to make now, is that one of the things, if you're aspiring to do research, is to leverage a grant you get in one area, especially if you're doing team science, to get grants in other areas. So, for example, a key collaborator, friend, and a colleague, Yijin Chen, who's in computer science at Washington University and whose expertise is in machine learning, we were leveraging the AHRQ work to get a parallel grant in the similar space from the National Science Foundation, from the NSF, and that was very focused on technical aspects of machine learning. At the same time, because we were doing a randomized trial, we put together another grant application, also building off this work to the National Institute for Nursing Research, the NINR of the National Institutes of Health. And from that, we got a 5-year R01 to do a clinical trial using this infrastructure. So it's very, when you're thinking about building a research program, use the foundational work that you're doing and use it to get resources from other specialized areas. I'm sorry if that was not related to the question that was asked, but I really wanted to convey that as a positive and encouraging message to the audience.
Well, thank you for making that comment. I think it's important. So our next question is also for all of you. So regarding inherent bias and natural language processing algorithms, how do you safeguard against racial or gender bias so in your algorithm?
So I'm very excited because I would have seeded this question if I could, to tell you that part of what my PhD student did was go back and evaluate our algorithm for bias, because this was a concern. And so why don't we go ahead and double check and see if our algorithm is biased, because this is the best way to protect against it, is you check and you look at your results. And so I'm excited because I can promote some of his work and promote his publication and tell you that it was not biased. But I'll let the other panelists answer as well. Is the best way you can worry about bias is you go back and make sure you don't have it. You need to check on your own as well from your data and make sure for some reason your data aren't inherently biased or your algorithm's not picking something up from them.
Yeah, I'll just say briefly that truthfully, I don't know that our algorithms are unbiased, but this is part of the focus in follow-up work and grant funding that we've acquired, is to look at this as one of the questions. It's a really good question, and I'm sure that the questioner knows that that's a big problem often in machine learning work that has been done, that there are biases, they're often systematic, and they're often attributable to the problem that of representation and underrepresentation of specific groups when we are building algorithms and from the data that we have. So thanks for that question, for sure.
And I completely agree with my colleagues that this is a very important aspect that we should all be on the lookout for. And yes, thank you for the question.
So the next question, I know none of you used patient-generated health data in your research, but this the participant is wondering, so is it possible at this time to compare the accuracy of patient-generated health data versus healthcare worker-generated data? Should PGHD be used in future research? How will PGHD impact future research?
So in the case of ours with the epilepsy, the easy way to say that a patient-generated health data could be reporting on their seizures and their signs and symptoms and things that they're going to be saying to the provider anyway. I may not be a great example for how to include patient-generated health data. It can absolutely be included in the future, though, and there are ways to bring patients into research since a lot of our results directly impact them, and they should be brought in future phases as well.
Yeah, I mean, I endorse that fully. I think it's another really excellent question. I think that our research has to be patient-centered, and our patients should be our partners in the research that we do. I think that it depends. Some environments it's easier than others. So, when patients are anesthetized in the operating room, it's harder for them to generate their own data or to participate directly. But in the wider perioperative context and the evaluation of risk takes time over a continuum, we're actually looking at now generating risk scores for readmission, for example, where patients would provide information in the preoperative period and postoperatively and even after hospital discharge. And there are so many wearable devices now which can contribute data that I think are very helpful and can be integrated, some of which just collect data passively, but some could certainly have active participation from participants, for example, filling in daily surveys on a smartphone would be a good example. And these are ways that are patient-centered and patient participatory. And we want to do that, and we encourage others to pursue those avenues as well, for sure.
And I completely agree. Whether when and where patient-generated data is helpful really depends on the research question that you're asking. So there are some research questions, some outcomes where patient data can be indispensable. So in my field of diabetes, for example, studying hypoglycemia is where it's really difficult to get information or any kind of reliable information on hypoglycemic events from anything other than patient-generated data because there are no other good sources. So it really depends on what you're studying. Just like with any kind of research project, you pick your tools that are the best ones to answer the question that you're asking.
Thank you. And you all have shared excellent use individually, like different use cases. So how can we move forward as a healthcare community collectively with the use of machine learning and algorithms? It's a much bigger picture question.
I think there's a potential for moving forward with all of us if we develop good standardized ways that share our data and allow us to perform larger studies and make inferences off of larger shared data sets that we can provide and find more rare events and make stronger determinations based on just knowing we have a more robust, sound data set.
I will second that, and I think as we learn to share our data and our tools that we have developed, that will allow us to generalize our findings and to disseminate them. So that, for example, was one of the motivations for our creation of the Canary natural language processing platform, because we wanted to enable others, other people who develop natural language processing tool to share the tools with anyone who is using the same platform.
I mean, this is a wonderful question, coming to the end, and it's actually quite complex, and I think in a way a bit political. So, I'm idealistic and I'm optimistic, and I think I see these traits in my fellow panelists, and certainly we would love to be sharing algorithms and data and creating something that benefits the whole of society. But I think we also have to be realistic that that's not how healthcare is in the US currently. There are lots of barriers to that. There are companies that own a lot of the electronic health record data, and they may see that there's a big profit in that. So there are barriers to sharing and to developing these resources that benefit the whole of society. And I think that to some extent there will be political inputs into these decisions, and it will depend on the goodwill and the philanthropy of many of the key players in this space, whether it's some of the big corporations in healthcare and outside of healthcare, whether it's Google or Apple or Epic or Cerner. All of these companies will need to come to the table and be involved in this and work with the scientists and the researchers in terms of doing things that are to the benefit of society. And I also want to make a plea with something that I did say earlier, and the theme to which we referred is that we shouldn't forget that we can also become over reliant on technology, and to remember that healthcare is always going to be about an individual, a human being, and that the contact at a human level, that the empathy in healthcare and caring for each individual is also something that we who are in this space should not forget, which is actually a point that Eric Topol makes very strongly in his book Deep Medicine, which I think is a great book to read for those of you who haven't read it yet and who are interested in this area.
Thank you. I want to thank all of the panelists for the great discussion. And so I think we have reached the end of our time for this webinar. So thank you all for attending. For those interested in obtaining continuing education credit for participating in this webinar, please visit the URL shown on this slide. And so you will select today's webinar, which will be indicated by date and title to claim your credit. You will have 14 days to claim your CE. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we hope that you will complete this survey to share your feedback with us. So thank you all very much for participating in this webinar today, and we hope you will join us for future learning opportunities.